Hey everyone, it's me again. Welcome back to another episode of Physiology 2, especially for you. In this video, we will look at the physiology of the heart. In the previous video, we looked at the heart and we finished with the gap junctions that showed how the electrical signal can just spread from cell to cell in order for the heart to function as one big unit. And if you want to measure this activity, then you can use, for example, some electrodes in order to create what we call an ECG, electrocardiogram. And that will basically make a 3D recording of the electrical flow through the heart. And that is something that a cardiologist, or at least someone with experience in reading those ECGs, can use to determine certain abnormalities, for example. For you in this course, it's all about the basics. So what I expect from you is that you understand the underlying idea of the ECG and that you understand what happened during the P wave, the QRS complex, and the T wave. So let's have a look. But first, the standard placement of the electrodes is visualized right here. And on the left, you can see what that then would represent. So with these placements, you should be able to have a 3D image of the electrical flow. So in all directions, and that is then visualized graphically in this traditional ECG diagram. This ECG, as the name suggests, is about the electrical flow, and then the different letters are assigned to different events or in different moments of this cardiac cycle. The P wave is showing at the point where the atria depolarize. So it's the first part of the cardiac cycle, as you know. So the P wave represents the depolarization of the atria. But then once the atria have depolarized, the signal will spread, as you know, and the ventricles start to depolarize while the atria repolarize at the same time. And that is covered under the QRS complex. So it's not possible to separate those events, but the QRS complex happens when the atria repolarize and the ventricles depolarize. After the depolarization of the ventricles, you expect the ventricles to repolarize, to relax, to refill, and then you expect in a normal ECG, you expect a horizontal ST segment followed by a T wave. Now, one of the examples of what a cardiologist could read from an ECG is an oxygen deficit somewhere in the heart, and that could be represented by this ST segment showing a depression, as they call it. So it's basically the line that is no longer level, but is going down slightly. And that could be a sign for the cardiologist to say there might be an oxygen deficit somewhere. Let's look into it for further details, for example. For you in this example again for this course, P wave, QRS complex, ST, and T wave. In this picture, you can see the same thing, how the ECG is building up from the start of the cardiac cycle all the way to the end. And then right here, what is nice is that it is adding the actual event visually. So here you can see in yellow marked the whole depolarization of the atria, followed by here the depolarization of the ventricles. So you can nicely see how the event is synchronized to the actual recording, and that should help hopefully in the understanding of this ECG. Well, the heart, as mentioned before, has a natural rhythm of 100 beats per minute. So without any input, it would beat at that frequency. But normally we have a lot of input. We have parasympathetic input, sympathetic input, we have hormones, we have other influences. So it is a complex system of regulation that will push up or down the heart rate. In this picture, you can see all these different factors visualized. We've seen before the sympathetic input, we've seen before the parasympathetic input. Again, the difference is that the parasympathetic input is only focused on the atria, whereas the sympathetic input is focused on both atria as well as the ventricles. And you can see also here through the bloodstream that the ventricles are actually targeted by the sympathetic influence. So epinephrine for example, can have an impact on the atria, on the SA node, but also on the contractility of the ventricles. Here you can see especially that last separation in a little bit more detail and simplified. The parasympathetic input right here, the sympathetic input right here. The sympathetic input goes in two directions, through the direct connection through epinephrine or norepinephrine as the transmitter, acting on the beta receptors on atria and ventricles, whereas through the bloodstream, also epinephrine can influence the beta receptors, and that especially will impact the ventricles and the contractility of the ventricles. The parasympathetic input through acetylcholine as a transmitter will focus only on the atria, and the difference here is that it will downregulate the ion leakage in order for the frequency to go down of the SA node depolarizing, whereas all these transmitters through these receptors will cause the leakage to speed up in the SA node, which will cause the depolarization to occur at a faster frequency, and that will then also push up the heart rate frequency. In this graph, what you see is this leakage that I mentioned just before. The leakage is normally, as represented in green, relatively slow. And here you can see that the green line represents ions leaking. On the left, you see the membrane potential in millivolt. And here you see the time. So in a normal control situation, the green line represents that there is ion leakage through the membrane, which will trigger the membrane potential to slowly get closer to the threshold. If the threshold is reached, as you've covered before, you will expect a complete depolarization, and that's what you see right here. And that is then determining also the frequency of the next depolarization. So the whole heart rate frequency is determined by the frequency of this ion leakage. But then if you look at the purple line, the parasympathetic stimulation will cause the leakage to go a lot slower, and that will then also lower the frequency of the depolarization of the next one, and that will then lower the heart rate frequency. The opposite happens if you look at sympathetic input, where you see here that the yellow line represents faster leakage of ions, and that will cause the depolarization to occur faster. And then again, the next depolarization is also expected to be faster, and that will cause the overall heart rate to increase. Okay, then we will look at the heart and the bigger picture of how the heart generates blood flow, generates cardiac output. But first, we need to understand that if activity goes up, the heart will need to provide the whole body with more blood, with more oxygen. So this is the first step towards exercise physiology. What you see in this graph is, or in this table, is the division of blood flow. And here at the bottom, you see that normally you would expect someone to have roughly a cardiac output of 5 liters per minute. So a normal person, average size, will have around 5 liters of blood, and that amount of blood is pumped through the whole body, usually around once per minute, and that will give you at rest a cardiac output of also 5 liters per minute. You can see that at rest, the abdominal organs receive quite a percentage of the total, but also your skeletal muscle and other organs will receive a certain percentage of that cardiac output. So the body needs to make choices, and at rest, this is roughly the division that you can expect. Also, the brain should get a certain amount of milliliters, which should correspond in this case to a certain percentage. And if you compare this to the blood flow during exercise, you see that the body really needs to make important choices during exercise because blood flow is limited. So, for example, the abdominal organs cannot receive the same percentage as they can during rest. But before the heart can actually function, it also needs to have its own blood supplied. So the blood is not supplied through the inside, although you could argue there's already a lot of blood inside the ventricles, so why not have it diffuse from the inside? No, the heart needs to receive its blood through the outside. So through the coronary arteries that are positioned here on the outside of the heart, the blood is reaching all the different cells to supply each cell with O2. It's a relatively delicate system. If you look at the complexity of the heart, then this is definitely a weak point in the design. But the heart basically gets blood through, after the blood leaves the heart, after the blood enters the aorta, it will just directly move out of the aorta and will move into the coronary arteries to supply itself with blood. If you look at these numbers, then you see that these are relatively high numbers. So at rest, from all the blood that is passing through the coronary arteries, roughly 70 to 80% of all the O2 that is passing through, that is available, is already extracted. If you compare that, for example, to the capacity of the pulmonary system, you see major differences here, where the heart apparently doesn't really have much overcapacity, not even at rest, whereas the pulmonary system has overcapacity even during exercise or during maximal exercise. So this is one of the main indicators of the difference between the heart being the real limiting factor and cardiac output really being the limiting factor during exercise, whereas the pulmonary system for normal healthy people is never going to be a limiting factor during exercise. So the heart really needs to bring up blood supply to itself in order for it to function and to supply blood to the rest of the whole body. But if there's a problem with the oxygen delivery, then you could either have angina as an outcome, or worse, you could have an infarction. Angina is a temporary obstruction or a temporary issue with the oxygen delivery, and that could cause chest pain, but it can also go away. Whereas an infarction is actual deprivation of O2 for a longer period of time, which will cause certain cardiac cells that are completely deprived from O2 to die and to really lose its function completely. And depending on the size of that damage, it could either go unnoticed if it's super small, or it could be fatal if it's a very large area. In this picture, you can see how that could look for a certain area here. In this area is normally supplied with blood through this coronary artery, and if you imagine that there's an obstruction right here, then all these cells right here will no longer receive blood and will no longer receive O2. And if this is happening for a longer period of time, these cells will literally die and will completely lose their function. And like I said before, if it's a small area, might not be really problematic, but if it's a bigger area, it definitely will be very problematic. So a heart attack, a myocardial infarction is definitely something that you as a physio will encounter. So it's important to understand the different levels and what the possibilities are later for exercise that is still possible, for example. Myocardial infarction we mentioned, but high blood pressure is also something that as a physio you can expect, and as a patient category that is directly related to what we're covering in this video. Angina we mentioned, so angina and infarction as related categories, but also heart failure. If a patient's heart is really failing, which means that stroke volume is no longer in proportion to and diastolic volume, for example, then someone could really have capacity issues for exercise or even daily living activities. And finally, also valve issues could be present. And especially in the last category is what we'll focus on for the last few slides to show you how the valves operate in a normal situation, so that in case of a pathology, you can imagine what could be the consequences. Obviously, as a physio, the first response should always be that for all these patients, physiotherapy is definitely a good option. But in many cases, medication is also included. Plus, sometimes surgery is the only real option to tackle the underlying pathology. And in cardiology, they're really a big fan of abbreviations. So CABG, coronary artery bypass graft, is a bypass in short that will just bypass any obstruction in order for the surgeon to bypass the obstruction and have the area that was short or deprived from O2 to still get O2 delivered through this bypass. PTCA is percutaneous transluminal coronary angioplasty. Angioplasty, in short, is about opening up the coronary artery, for example, through a stent, in order for the obstruction to be eliminated as another way compared to the bypass to deliver O2 to the affected area. If none of these options work, then sometimes you will see that a transplant is the final resort in order to hopefully restore some of the normal function of the cardiovascular system, and in particular the heart. But to get back to the overall blood flow and the functioning of the valves, in this graph, what you see is how the blood should flow, and it's all about pressure differences, remember? So if the pressure in the right atrium exceeds the right ventricle's pressure, you will have the blood flow from atrium to ventricle because the valve will open in this direction. As soon as the pressure in the ventricle starts to build up and exceeds the pressure in the right atrium, this valve will automatically be pushed to close. And if the pressure rises a little bit further, at some point the pressure here will exceed the pressure on this side of this semilunar valve, and then the blood will flow out through this valve because this will open. Blood flow back is then automatically blocked because if the blood starts to flow back because the pressure difference is now that the pressure is higher here than in the ventricles, blood flow will be restricted in the wrong direction if the valves are functioning normally. On the left side, exactly the same thing. And for the AV and the semilunar valves on the right and left side, it basically means that they're operating in sync. So the right side does exactly the same as the left side. Well, this video I played a little bit earlier, so definitely I would highly encourage you to have another look at this video to fully understand this whole cycle, this whole cardiac cycle of relaxation and contraction and how everything works together. All right. Finally, to finish up with some valves and the valve or the heart sounds, the valves will open passively. We do have some small papillary muscles attached to some of the valves, but in short, you can just say that valves will open as one-way valves to prevent blood flow in the wrong direction and only allow blood flow in the right direction, just by pressure differences. The typical heart sound, lub-dub, 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 that you might have heard before is caused by the AV valves and the semilunar valves opening and closing, and especially the closing of both in sequence is what will determine the sound. So if a valve is open and it's pushed to close, then it will create this sound. So in the sequence, the AV valves are expected to close first in the sequence, so that's why they cause the lub sound, and the aortic and pulmonary valves are expected to close afterwards, and that's what makes the second sound the dub sound. And finally, here you can see the same picture as I showed you before, where the valves show to be open, or at least partially open, allowing blood flow towards you from the viewer's perspective. If the blood would flow in the other direction, because of the shape of these cusps, they will automatically be pushed to close, and that will create this closing sound. And here you can see the valves being almost completely closed, so a little bit more pressure pushing the cusps together will completely close the valve, stopping blood flow in the wrong direction and having the whole cycle start again. All right. To finish up, a summary of the diastolic phase, where you see the blood flow in the different directions in combination with the actual state of the valves. So make sure that you understand at what point of the cardiac cycle a certain valve is open and at what point a certain valve is closed. So for the diastolic phase, the relaxation phase, you can see here the whole situation with blood flow and the valves. And here you can see for the systolic phase, the opposite, where you have flow here in these pictures, and here the positioning of the valves. All right, that was it for another video. Thanks for watching. I hope you like it, and let me know if you have any questions, and I hope to see you soon in the next video.